Okay, I'm going to go ahead and get started. I wanted to tell you just a little bit about our speaker today. Dr. Ajayi is coming from Houston today, but has been all around. He has taught in many places. Originally, he got his university education in Glasgow, Scotland, and did I pronounce that correctly? In Nigeria. He also has received a PhD in clinical pharmacology in Glasgow, and as well as basically his MD degree at IFA in Nigeria as well. He's also done quite a bit of research on hypertension, angiotensin regulators, etc. He's held professor positions at multiple medical schools and taught in the Caribbean as well as the United States, or mainland United States. And he has written a very interesting book that I wanted to mention. I thought it would be interesting for this group in particular to know, if I can just get the title proper. So, hold on. Basically, he has an expert in global health and has written a book having to do with global health and disparities amongst peoples of different ethnic groups and economic classes in health. So please welcome Dr. Ajayi to our school today to give a talk on glaucoma.
Thank you very much for your warm introduction. I'm going to talk today on glaucoma. And the reason why I'm choosing this topic is because, one, it's of medical importance. It is prevalent in this area. It is commoner amongst Black people, Hispanics, than it is among Caucasians, and it's least common amongst people who are of Asian origin. So there's an ethnic variation in the spectrum. The other reason why I chose this topic is because it illustrates the integration that is possible between the branches of basic medical science, from anatomy to physiology, to pathophysiology, to pharmacology. So in terms of the breadth, it gives us that breadth, and in terms of the depth, it also links up pharmacology to clinical medicine as well as to other things you'll see later. So that's why I chose this topic. How do I advance?
This one right here. You turn it on, and then this is your advanced button right here.
This one?
This one right here. So this forward and reverse.
Okay. I usually give lecture objectives to my students. So although you're not my students, but I pretend that some of people here are my students. So I usually give lecture objectives to my students in a class, the lectures I give. The lecture objective is in this particular presentation is to know the ocular anatomy and the aqueous humor physiology and production, and the determinants of aqueous humor production, as well as to know the mechanism of neuroprotection of the retinal optic nerve, because the ganglions of the optic nerve are targets in glaucoma, because there's an axonal degeneration, there's apoptosis, which follows increased intraocular pressure. Then the other components of the lecture objectives are to understand the role of the adrenergic, cholinergic, prostaglandin receptors and their signaling pathways in the formation of aqueous humor and the physiology and pathophysiology of raised intraocular pressure. Then thirdly, to know the different drug classes used to treat this condition, so as the individual drugs within each class and where they may be preferred to other drugs in the same class. And lastly, to recognize that there are ethnic variation and that this is a classical case in which personalized medicine may be useful in choosing the best treatment for a particular patient, and also the role of genomics and the recent cutting-edge aspects of medicine, which is nanomedicines. This is a condition in which nanomedicine are being used to treat the condition. So the lecture outline will follow this pathway: definition, epidemiology, anatomy, physiology, pathophysiology, clinical presentation, and treatment options. And at the end, I'll give a clinical vignette for the students to practice by. So what is glaucoma? Glaucoma is not just one disease, it's a group of diseases. It's a group of diseases So it's a group of diseases that is characterized by progressive nerve damage to the optic nerve head. And it's usually painless and leads to loss of vision. And there's increased risk of total blindness in patients who have it. The optic nerve damage usually results from increased intraocular pressure. And this pressure causes glaucomatous optic neuropathy. And glaucoma can still occur with normal or even below normal intraocular pressure. So it's a very, very diabolical disease because you can't use pressure alone to determine its occurrence. So how do we classify intraocular pressure? Just as we have hypertension, we also have ocular hypertension in the eye, raised blood pressure. The normal range of intraocular pressure measured in millimeters of mercury by a tonometer. This is a tonometer. It's a puffed thing. It puffs into the eye and the reflection gives the pressure. The normal range is between 10 and 21 milliliters of mercury. Ocular hypertension is defined when the intraocular pressure is more than 21 milliliters of mercury. But there are no signs of glaucoma. Glaucoma occurs when there's IOP greater than 21, in addition to signs such as loss of peripheral vision. You can't see what's on your sides. There's tunnel vision. You just can only look forward and look straight. And then there's dimness of vision, amblyopia. And sometimes there's ocular pain. Those are the classical symptoms of glaucoma. But to make matters complicated, you have what is called normal pressure glaucoma. That is, the pressure is within normal range, but the person still has these signs and symptoms of glaucoma. So it's not just the pressure alone that determines whether the patient is glaucomatous. You have to examine the eye to see the signs of glaucomatous change. So epidemiology and classification. Worldwide, about 70 million people are said to be affected by glaucoma, and about 10% of these are already blind from glaucoma. They're already blind from glaucoma. In the United States alone, about 3 million people are affected above the age of 40, and about 130,000 Americans are already blind from it. The incidence is also rising fast. It rises steeply after the age of 60, 65. And the most common cause is the most common cause of blindness among Hispanics and African Americans. Okay, and African Americans have 3 times the incidence of glaucoma compared to Caucasians, and 4 times the incidence of blindness. I think the Hispanics are in between the blacks and the Caucasians. And then what makes it also very, very diabolical is the fact that only about half of the patients are ever aware that they have glaucoma until they get blind. So let's look at the ocular anatomy here. This is the eye in cross-section. This is the lens. In front of this is the iris, and this is the cornea. So anything from the lens to the front part from here to here is called the anterior chamber. This is the vitreous humor. The aqueous humor is produced from the ciliary body mostly, and it goes into the anterior chamber from here to here. So what happens in glaucoma is when there's increased intraocular pressure. When there's increased intraocular pressure, this pressure here, because the eye is in a rigid bone, is going to have ultimate effect on the optic nerve and compress the optic nerve and cause glaucomatous damage and cause apoptosis of the ganglionic neurons in the eye, which are not replaceable. And so that's the problem with it. So this is the aqueous humor. It's produced from the trabecular meshwork, the ciliary body, and it produces from here and goes to the iridocorneal angle. This is the iris and this is the cornea. This angle here between the iris and the cornea is known as the iridocorneal angle or the IC angle. So let's aqueous humor dynamics. Since aqueous humor is produced and also exits, for it to be a factor in the intraocular pressure and therefore its consequences downstream, there must be a balance. So the intraocular pressure is a function of the aqueous humor production rate, that is the inflow from the ciliary body going to the anterior chamber, and the outflow rate. So you can have increased intraocular pressure from either increased inflow or reduced outflow. And the outflow rate is inversely proportional to the venous pressure or venous resistance. So when the venous caliber of the vessels is reduced, the resistance will go up by Poiseuille's law. And once the resistance goes up, then the outflow will be reduced. But the converse is true. When the venous resistance reduces, the outflow will increase. And you'll see how drugs affect that when we go on. So the exit pathways for the aqueous humor, 96% of it occurs at the iridocorneal angle that I also earlier mentioned. So, and these are the trabecular meshwork, the trabecular outflow, also known as the trabeculocanalicular outflow. The canal there is the canal of Schlemm, which I will talk about later. And then the uveoscleral outflow and the ciliary muscle itself. So there are several pathways by which the aqueous humor exits. And then there are also some degree of reabsorption, but it's not very significant, but it occurs. So you can, from this, increase in intraocular pressure occurs mostly from increased outflow resistance. That is, anything that blocks the exit will increase intraocular pressure more than anything that increases production. So the main thing that causes pathophysiological mechanism of causing ocular or glaucoma is reduction in the exit of aqueous humor produced. So this is a more detailed diagrammatic representation. The ciliary body produces the aqueous humor. The aqueous humor flows that way. This is the iris there, and this is the cornea. So this is the iridocorneal. This is the iridocorneal angle. You can see it's a bit of an acute angle there. So iridocorneal angle is where 96% of the exit occurs, and this is the canal of Schlemm. So this is the trabeculocanalicular outflow, which, as we'll come to see later, is affected mostly by muscarinic agonists. And this is the uveoscleral outflow, which is affected mostly by prostaglandins. And the aqueous humor inflow, the production, is affected by beta blockers and some other drugs we'll talk about later. So I hope this is clear. It shows the closer anatomy of the exit pathway. So adrenergic control of the intraocular pressure, adrenergic nervous system control. Increased intraocular pressure occurs under the influence of beta adrenergic receptors, such as the adrenergic receptor 1 and 2. And this is a G protein coupled receptor. It's a heptahelical receptor transmembrane, and it is coupled to GS. And GS, as you well know, as I will show later, will stimulate adenylyl cyclase and raise cyclic AMP. So increase in GS will cause IOP to grow up. So stimulation of the adrenergic receptors will increase IOP. So to reduce IOP, we have to give a drug that blocks the adrenergic receptors, which are the beta blockers. But then the other problem which we encounter is the fact that there's a lot of polymorphisms of the adrenergic receptors, which may contribute to a high incidence of IOP and the variation in therapeutic response. So the ethnic variation we see between peoples may occur because of the polymorphism of the adrenergic receptors, as well as other factors which I have not yet mentioned. For example, the color of the iris. It's been shown in Caucasians that even people who are Caucasians, the darker your iris, the less responsive you are to beta blockers. Yes, because the melanin in the iris competes with timolol, a beta blocker. So there's a competition. So when there is when your iris is dark, you have less response to timolol. But when your iris is lighter blue, you have more response to timolol. So it's not just a receptor thing, there are other factors involved. So this is just a diagram to further elucidate the receptor pathway involved. So I said the adrenergic receptor is heptahelical receptor transmembrane, seven membrane domain spanning receptor that binds to GDP and the heterotrimeric G proteins and splits GTP under the influence of adenylyl cyclase, which is the amplifying enzymes, and produces AMP, and AMP is converted to cyclic AMP. And the increase in cyclic AMP will phosphorylate protein kinase A, which will now cause these downstream effects. Okay? So then the converse, how the autonomic nervous system controls IOP. The autonomic nervous system can also decrease IOP as opposed to increasing IOP. The decrease occurs under the influence of the alpha adrenergic receptors, in contrast to the increase due to the beta adrenergic receptors. The alpha 2 receptors in particular are coupled to GI, among many other things they're coupled to. They're also coupled to GQ, but they're coupled to GI, which reduces cyclic AMP level by inhibiting adenylyl cyclase. And by decreasing cyclic AMP levels, to decrease the aqueous humor production and may actually increase uveoscleral outflow. Therefore, because this is a beneficial response, alpha-2 agonists, which mimic the effects of alpha-2 stimulation, will be useful in the treatment of glaucoma. Now, this is a fairly complex diagram to show the receptors I've been talking about. The beta adrenergic receptor, which we said increases adrenergic IOP, working with the alpha S and the gamma and the beta heterotrimeric G proteins will stimulate adenylyl cyclase. Okay, when it stimulates adenylyl cyclase, it increases cyclic AMP. Cyclic AMP, working through, will inhibit myosin light chain kinase, and will also increase protein kinase A activity, which will block production of calcium entry into the body. So all of that will lead to contraction, which will raise intraocular pressure. But conversely, alpha-2 adrenergic receptors, which act mostly by alpha-1, the heterotrimeric GS1 inhibitory, will block adenylyl cyclase and therefore reduce cyclic AMP and have the opposite effect on preventing the contraction due to myosin light chain kinase. So this is just to show alpha-1 receptors act like prostaglandin receptors and other receptors. We'll come to that later. So this is just a diagram to show the various pathways in the signal transduction process that leads to IOP production. So ocular smooth muscle regulation, again, apart from the adrenergic nervous system, the vagal nervous system, the parasympathetic nervous system too has an effect on the regulation of IOP. The smooth muscle of the iris, trabecular meshwork, and the ciliary muscles contract in response to M3. There are up to 7 subtypes of the muscarinic receptor, but the one that regulates IOP is the GQ protein coupled receptors of the muscarinic acetylcholine receptor, and this causes increase in cytosolic contraction and cytosolic calcium. The retina has M1 to M5. The muscarinic contraction keeps the IOP normal because when it contracts, it causes meiosis and reduces the iridocorneal angle. An increase in iridocorneal angle allows more of the aqueous humor to go into the anterior chamber. And examples include pilocarpine, I didn't show that here, carbachol, and the antagonists, which can reverse all these, are atropine and scopolamine. Okay. So this is a detailed example of what happens with the muscarinic receptor. This is M3, the one that's responsible for the eye changes. The M3 is coupled to alpha, beta, gamma, GQ, as I said. And it stimulates, when they bind to the receptor, it stimulates phospholipase C. Phospholipase C breaks down phosphoinositol biphosphate into inositol triphosphate and diacylglycerol. IP3 stimulates more release of calcium from the sarcoplasmic reticulum, and the calcium that is released binds to calmodulin. The calmodulin then forms a calcium-calmodulin complex and acts on myosin light chain kinase, leading to contraction. So that's the contraction of the iris body will cause miosis. Whereas here, the IP3 DAG protein kinase C too has an effect, and that's how these various receptors and signal transducer pathway act to cause the effects on the eye that we are going to describe. Okay, I don't think this will add much to what we're going to see today already. Now, this is just another way to demonstrate what I've said before. Beta receptors acting through GS, acting through adenylyl cyclase, will convert ATP to cyclic AMP and cause smooth muscle contraction and will raise intraocular pressure, in addition to the other things they cause. And the alpha-2 receptors acting through GI will also block adenylyl cyclase and prevent conversion of ATP to cyclic AMP and therefore cause smooth muscle contraction. Alpha-1 receptors are not that involved in the actions of drugs for the eye. So, yes, ma'am.
So, because I don't want to get lost. So, the contraction of the smooth muscle is resulting in, is it not just pushing the fluid into the anterior chamber or the posterior chamber of the eye? Or I don't understand what you were saying it was doing in addition to that.
No, the cholinergic agonists, they act on the trabeculocanalicular network. There's the canal of Schlemm. Yes, that's how they act.
Okay, and so it's acting there on the.
So when they contract, they help to push the fluid acts.
They're causing basically pushing that fluid out of the eye completely, or not, or into the posterior chamber.
No, not the posterior chamber, to the anterior chamber through the canalicular to exit the eye.
To exit the eye.
Yes, but at the same time, the contraction will reduce the diameter of the pupil, making it myotic.
Anti-myotic, so that means.
No, it will be myotic. It will be smaller.
Smaller.
Yeah.
Okay, I got it.
Yeah. So another receptor which is important, and which is the prostaglandin F2 alpha receptor. The prostaglandin F2 alpha receptor, which is another factor, because one of the prostaglandins, which we're going to talk about, also act on the prostaglandin receptors. There are two main kinds of receptors that they act upon. There are two main types of receptors. You can see the prostaglandin pathway from arachidonic acid through COX-1 to cyclic endoperoxides to PGH2. But what I want you to note is the fact that from PGH2, PGF synthase produces PGF2 alpha, which is the agonist we are really interested in. And PGF2 alpha acts on the PGF receptor to cause increase in cytosolic calcium and inositol triphosphate, which is acting through GQ. And at the same time, there are some prostaglandins that act not on this receptor, but act on the prostaglandin E2 receptor and increase cyclic AMP. So I just wanted to note that. So this is more direct evidence of what happens with these receptors. The prostaglandin F2 alpha acts on the receptors, acts on the receptor through GQ, and then causes a series of actions. But what I wanted to note with prostaglandin receptors here is that it's not just a surface-bound receptor alone. It's a cytosolic receptor. It binds to cytosolic elements and also acts on the nucleus. So prostaglandin receptors acts on the nucleus, acts on the cortisol responsive elements on the DNA of receptors, and leads to protein synthesis. So it's not just like the beta receptors which are surface bound, but they have additional actions on the nucleus and affects protein DNA transcription and translation and protein synthesis. So it's a very, very important action that differentiates it from the other agonists we'll be talking about. And then the PG2 receptors act on the EP receptors, and through GS also acts on protein kinase A and also acts on the nucleus. Some of them by binding to HSP90 also acts on the DNA to cause transcription and translation and affects formation of RNA in the trabecular meshwork. So this is very, very important concept to grab. So in terms of ocular smooth muscle regulation, the ocular endogenous function, we have PG receptors, which have mRNAs of PG receptors, and they're located in the trabecular meshwork, and they're also located in ciliary muscles and sclera, and indicate their role in the aqueous humor drainage, as well as in the uveoscleral and trabecular outflow. So the prostaglandin is not just one that acts on the aqueous humor production. They also act to change the exit of aqueous humor in the various outflow mechanisms. When we are talking of topical prostaglandins, we are talking of latanoprost. There's no N there. It's not lantan. There's latanoprost, travoprost, and bimatoprost, and they release endogenous prostaglandins. And in addition to that, they have other effects on protein synthesis. And they do so because of the effects they already described to you on their transcription and translation of DNA. And because they do that, they can affect the matrix metalloproteinases. And they can change the structure of the matrix metalloproteinases by changing their RNA, and therefore they can remodel the extracellular matrix. And they can widen the space of connective tissues and increase permeability. And that's how they really are the most effective drugs today for the treatment of glaucoma, because they have these extra factors acting on nucleus and the RNA translation and transcription. Now, glaucoma types. Even though we've talked about the pressure differences in different things that causes intraocular pressure, we still need to classify glaucoma. The main types of glaucoma could be primary, that is, we don't know the cause, or secondary, is secondary to either trauma or eye infection. So we can have primary chronic or open angle glaucoma, acute angle closure glaucoma, and chronic angle closure glaucoma. These are the commonest. And again, they exhibit ethnic differences, because chronic open angle glaucoma is the commonest form of glaucoma in blacks and whites. But acute angle closure glaucoma is commoner in Asians. It's important to recognize that. There's an ethnic difference in the causation, there's an ethnic difference in mechanisms. In the chronic type, it's thought that the excessive beta-adrenergic receptor mediated production of aqueous humor contributes to the rise in intraocular pressure, and that this leads to back pressure on the eye, causing ischemia and retinal blindness from the apoptosis of the neurons of the retina of the optic nerve. And the prostaglandins are thought to mediate the filtration of aqueous humor via the trabecular meshwork, which I've said before. Whereas in the acute angle closure glaucoma, this can result from sudden apposition. If you remember that diagram I showed you of the iridocorneal angle, the trabecular meshwork and the canaliculi, if the iris is pushed forward, it can close the canal of Schlemm and obliterate the iridocorneal angle. When it does that, the ability of the aqueous humor to exit will be reduced. And once it's reduced, there will be sudden increase in intraocular pressure, and it could be it's an emergency. So acute angle closure glaucoma can occur or result from obstruction to the canal of Schlemm, canal of Schlemm. I don't want to go back. Canal of Schlemm, through which the aqueous humor is filtrated and exits. This sudden closure of the iridocorneal angle, that is due to the opposition of the iris to the cornea, can be caused by muscle relaxation. So any muscle relaxant, particularly the atropines, the homatropines, scopolamines, or beta-2 agonists can cause it. And then midriatics, such as anticholinergic drugs, atropine, pratropium bromide, and snake bite of the snake called naja, and the striking mambas, they can cause it too, because they have that property. And then beta-2 agonist relaxant, ritodrine, can cause it. And antidepressants, which have anticholinergic action, such as the selective serotonin reuptake inhibitors, can also cause raised intraocular pressure because they change the iridocorneal angle. So these are all the things that can cause angle closure glaucoma. So apart from what I've said, the other anatomical factors like anterior chamber thickness, concurrent use of beta agonists for obstructive airways disease, and can cause a transient rise in IOP, more than 35 millimeters of mercury, sudden intense eye pain, and acute red eye. These are the things that can, and then the use of anticholinergic drugs, pre or post operative ileus, or pre-treatment for pre-medication, overactive bladder, can all cause it. So acute angle closure glaucoma, because of the risk, can cause sudden blindness. When we have a patient coming for us for medical examination or for anything, we need to take a history of eye disease before giving any anticholinergic drug, because anticholinergic drugs can cause it. So you have to take a history from the patient about response to anticholinergic drugs. You also need to do an eye exam to see that any evidence, because it's not just pressure now. Changes in the ocular cupping can manifest evidence of glaucoma. So in general, I have this nugget that sometimes what is good for the bronchus, like a bronchodilator or other beta-2 agonist or a parasympathetic agent, may actually be bad for the eye. So when we are treating patients, it's always a trade-off between those two things. So how do we treat glaucoma? The principles are very clear. We want to reduce the aqueous humor production by beta blockade, selective beta blockade by beta-1 betaxolol, but let's know that African Americans and blacks and black people and Hispanic to a lesser extent respond less well to beta blockers and may actually show a rebound effect. That is, after some time when the pressure is lowered, the pressure may actually go up again and rise more than the baseline. It has been reported. And then other drugs that can be used include alpha-2 agonists like apraclonidine, brimonidine can also be used to treat glaucoma. The anti-adrenergic drugs act on receptors on the ciliary epithelium. But one thing we also need to know, apart from the interaction of the beta blockers with the iris, with the color of the iris color, darker iris color, reducing the efficacy. Another thing we need to understand is that there are genetic variations. Topicals may interact with oral medications such as timolol and quinidine, and the cytochrome P450 enzyme CYP2D6 affects the metabolism of timolol. So increased outflow of aqueous humor can be by alpha agonists like epinephrine or by prostaglandins like latanoprost. But these drugs show little variation between ethnic groups because they don't bind to melanin in the eye. Unlike beta blockers, these prostaglandins do not bind to melanin in the eye. So there's less ethnic variation in the response. They increase the outflow, they cause ciliary muscle contraction, and they increase iridocorneal angle, and trabecular meshworks are opened. And that's what the pilocarpine and the cabacol causes. The other group of drugs that can be used are the inhibitors of acetazolamide and the inhibitors of the inhibitors. I'll talk about that later. So in topical treatment of ocular glaucoma, of ocular beta blockers, I've already mentioned that. I'm doing this for redundancy's sake, to knock it in. The three main drugs are beta blockers are bectazolol, timolol, levobunolol. Timolol is the most effective, usually as a gel form. It blocks AD1 and AD2 and reduces aqueous humor production by reducing cyclic AMP. It is the most economical drug to treat glaucoma. It is the most economic drug to treat glaucoma, particularly in Caucasians. It is not very effective, as effective in black people and maybe in Hispanics. It exhibits ethnic and pharmacogenetic variation, as we've said, but then one thing is also clear, it has chronopharmacological effects. That is, its effect depends on when it is administered. It is more effective after a morning dose because it acts better during the day than during the night. So it's more effective after a morning dose. Bradycardia are some of the adverse effects of topical beta blockers. No reports of heart block, but heart rate may be low. It can lower blood pressure and cause hypotension. It can cause spasm of the bronchospasm, especially, and you have to take special care in patients who are on treatment or who are asthmatics or who have chronic obstructive airways disease. So beta blockers have limitations in that regard, and they may also cause rebound increase in intraocular pressure, particularly in black volunteers or black patients. And they are less effective in women compared to men, and there's also pharmacogenetic variation. Now, topically selective alpha-2 agonists, we've mentioned that before, apraclonidine and brimonidine. These are the mechanisms of their action. They are also mydriatics, but apraclonidine is used acutely because if you use it chronically, it stands the risk of tachyphylaxis. So you cannot use it chronically, you can only use it acutely. And it is brimonidine that can be used chronically to treat in patients who do not respond or are intolerant to beta blockers. That's the use of alpha-2 agonists. In patients who are not responsive or who are intolerant of beta blockers because have cardiopulmonary disease, then we can give them alpha-2 agonists. It is also neuroprotective. Neuroprotection means that these drugs, by their actions, reduce the damage and the progression of the apoptosis of the retinal of the optic nerve. So it's also neuroprotective like timolol. Sympathomimetics, the adverse effects include dry mouth and allergy. And there's also beta blocker intolerance, cardiopulmonary comorbidity, and can be used in adjunct with other drugs, the treatment of acute angle closure glaucoma. The cholinergic agonists, which are also the miotics, which I talked about the other time, the carbachol and pilocarpine are the most important ones. The agonists are the postganglionic acetylcholine M3 receptors. They act through PIP2, diacylglycerol, increase calcium to cause contraction and to increase outflow through the trabeculocanalicular pathway, and that also cause meiosis. They are not very effective too, surprisingly, in cholinergic, in people with pigmented iris. So if your iris is dark, whether you're white or black, it's not going to be very effective. And they are less effective than beta blockers, and they usually have to be combined with other drugs. And they cause myopia and amblyopia as well. The prostaglandins, latanoprost, these are the darlings of treatment of glaucoma now. Unlike beta blockers, they have increased efficacy at nighttime. They also exhibit chronopharmacology. They are more effective when you give them at nighttime. Okay, and the mechanism is, summarizing it again, is that acting through F2 alpha, GPQ, PCR, protein kinase C, they increase the uveoscleral outflow and induce formation of matrix metalloprotein and alter the extracellular matrix and break down in the ciliary body, and therefore increase uveoscleral outflow. So that the single most effective agent in the treatment of glaucoma. The major adverse effects of prostaglandin is what we call prostaglandin-induced iridial pigmentation, PIIP. I didn't include it here, but that is what I meant by high-risk pigmentation. But some people have a specific term for it: prostaglandin-induced iridial pigmentation, PIIP. And they also cause inflammation of the uvea. That is the single most effective agent and can be used, and they are minimally affected by ethnicity. And they also show little evidence, but it exists, of polymorphic genetic response. They can be combined with other agents, and they also lower IOP and exhibit neuroprotection. The carbonic anhydrase, I'm not going to spend so much time on it because these are drugs that are getting out of use. They're usually used as adjuncts to other drugs. The acetazolamide, methazolamide, dozolamide are used as adjunct. They are seldom used alone, and they can cause acidosis and loss of potassium, sodium, and bicarbonates. But they are useful mostly as IV agents, the treatment of acute angle closure glaucoma. So in practical therapeutics, the first line of treatment is to give a patient either topical blockers, topical beta blockers, or topical prostaglandins. Sometimes there's a combination of the two. There are some drugs that combine both beta blockers and prostaglandins. Second line drugs are the topical alpha-2 agents and the carbonic anhydrase inhibitors. The third line drugs are the pilocarpine and the prostaglandins. And the fourth line treatment is to give the patient laser treatment with trabeculoplasty or surgery. And the goal of all this is to reduce progression to glaucomatous optic neuropathy. So in the emergency treatment of acute angle closure glaucoma, the aim is to reduce papillary block immediately and reopen the iridocorneal angle. And you can do this by combining all these drugs at the time that is stated: alpha-2 blockers, beta blockers, cholinergic blockers, agonists, systemic carbonic anhydrase orally or parenterally, osmotic diuretics, what you give to try to reverse immediately, because if you don't do that, there is increased risk of blindness. And the same thing applies to chronic angle closure glaucoma too. You have to treat them aggressively, and ultimately the treatment is by laser iridotomy to prevent angle closure glaucoma repeating itself. So recent medical advances for the treatment of glaucoma involve the use of liposomes, which Dr. Laura Milleen is an expert on nanotechnology. Liposomes for lantanoprost is injected to the subconjunctiva of the eye and is delivered to humans with either ocular hypertension or glaucoma. And compared to pre-existing birth treatment, these drugs have been shown to cause 37 to 63% reduction in IOP from the baseline for more than 3 months compared to the 2 weeks fall in IOP prior. The best results are about a fall in IOP, intraocular pressure, for about 2 weeks from a single eye drop. But these drugs, this nanoliposome of latanoprost, can cause 37 to 63% fall in IOP for more than 3 months. That's a major, major advance. And then because of this, we have improvement in IOP control and therefore in compliance as well. But these drugs are still expensive, and we hope that the prices can be brought down to economic levels. So this is what a liposome looks like. It's usually it has a bimolecular lipid layer. There's one layer there and another layer there. And then the drug is usually within. It's an aqueous solution of the drug latanoprost. This is not for latanoprost. It's just an example of what a nanoliposome looks like. But these nanoliposomes have a greater bioavailability. They can penetrate to the cornea, they can penetrate to the anterior chamber, penetrate to the posterior chamber of the eye, and reach the site of action that is intended. So in terms of pharmacogenetics and personalized medicine of glaucoma, we've said before there's interindividual variation in glaucoma therapy, and this can result from several factors. One, the polymorphisms of the adrenergic and receptors. Single nucleotide polymorphisms can result from polymorphisms of the F2 alpha receptors, can result from polymorphisms of the gene that breaks down the beta blockers, the cytochrome P2D6, which is also known as the dibenzoquine hydroxylase. It also metabolizes so many drugs, particularly metoprolol and timolol. So this just shows you what happens with the various. All these polymorphisms can affect the are clinically relevant because they are thought to contribute to the pathogenesis of glaucoma, but not all of them contribute to interindividual variation in drug response. It's mostly the mutation at codon 27, whereby glutamine is exchanged for glutamic acid, that causes a great response, a fall in IOP. So people who have this variant, who have this mutants, have a greater response to IOP than ordinary people. Okay? And the same thing applies now to CYP2D6 metabolism, the enzyme that converts timolol. The gene that forms the enzyme can exhibit single nucleotide polymorphisms, insertions and deletions, or sometimes even doubling extra genes being formed. So people who have no gene, the null types, don't metabolize this enzyme at all, and they have very high levels of very high levels of timolol after ocular instillation. So these people have a very great fall in IOP. So these drugs are very effective in them. Timolol is very effective in people with null genes for the enzymes, CYP2D6. There are some people who are heterozygous or homozygous for the gene. They tend to have lower plasma levels of timolol, but we are not sure of whether that confers any benefits on them. Then there are people who have twice the genes, who have a duplication of the genes. This is 2XN, and they are known as the ultra-rapid metabolizers of CYP2D6. And these have very low levels of timolol, and therefore the drug does not act very well in them. But the problem with this null type is that even though the drug has greater fall in IOP, it also causes a greater adverse effects in them, like bradycardia, like hypotension, can also occur in those who have very great falls in response to timolol from this genetic polymorphism. Okay? So these are the various things that we need to bear in mind. I'll soon be done. The prostaglandin receptor 2 is not spared. The prostaglandin F2 FP polymorphism also has an effect on lantanoprost. The PGF2 alpha gene polymorphism, the single nucleotide polymorphism in the promoter regions of the intron of one of that receptor gene has been correlated to IOP response in human eyes. And it's been shown that those who have this mutation have a greater fall in response to latanoprost with this dose of the drug compared to other people. So this particular mutation helps. So this is just a summary of what I've said before. I'll just go ahead. There are controversial treatments that have been rejected for treating glaucoma. One of them is marijuana. There was a movement in the 70s and 80s asking people to use marijuana to cure this thing. But a study was carried out because it was alleged that cannabinoid receptors may have a role. But the study was carried out in which they used delta 9 tetrahydrocannabinol, and it was not shown to be different from placebo, the randomized control study. So the evidence today is not there. It's not proven. We don't know yet. And also, there's increased evidence that L-arginine, which produces nitric oxide therapy, may also lower intraocular pressure. But these are not yet established treatments. And so in summary, we've spoken about glaucoma drugs, how they reduce intraocular pressure and protect the optic nerve, neurons, and prevent blindness, and that increased aqueous humor production is the main determinant of IOP. The beta blockers are the most economical, but show polymorphic response and diurnal activity. The prostaglandins are the single most effective agents and show less interethnic variability in response to IOP treatment, and also exhibit nocturnal efficacy. And that acute angle closure glaucoma, which is common in Asians, are effective, is an emergency condition and needing drug combinations. So I presented clinical witness. I don't think I'll be able to go through it because it's mainly meant for the students about what I think, whether they understand this lecture from my lectures. So they can check that out later. And I want to thank you for listening to this lecture.
So are there any questions for Dr. Ajayi today from the back? Like, I actually had one.
Okay.
It has to do with personalized medicine.
Yes.
And I know you're at Baylor, which is really actively pursuing this as a route. So you mentioned several mutations that would preclude or perhaps tell you that certain drugs are better for them, right? So are people actually doing that for glaucoma at this point?
Not yet.
Not at all, right?
Not yet. It will get there. That is more so for in oncology.
Mm-hmm.
But I see those as events. But I think that will come when that is necessary. But the other factors, factor, and the receptor, the other factors like the F2 alpha and the color of the iris and CYP2D6, all those things. I know that for Vicosip, for vitamin A, for oxide reductase, that's something that's being done.
Uh-huh.
To know what it does and phenotype the genotype and coagulants to the patient. And also, now we have new anticoagulants. So maybe we should most drug companies don't like to have a drug that has different molecular cosmetic output because it costs them more money to produce and to manage.
Nope. Okay, well, thank you for coming. I appreciate your attention. Oh, do you have a question? Okay, thank you.